Welcome everyone to the leadership webinar, Making Sense of the Policies Behind Healthcare Reform. My name is Janine Hopkins. I'm a principal at Santis Health, and I'll be presenting the session along with my colleague Dan Carpin, who's also of Santis. And we're supported here by a great technical team. This is the second of two webinars this month, and it's really specifically designed for leaders in the primary care, mental health and addictions, and community and home care sectors. What's unique about the series is that it's a collaboration between 5 associations representing all of your sectors, including the Ontario Community Support Association, Addictions and Mental Health Ontario, Canadian Mental Health Association, the Association of Ontario Health Care Centres, and the Association of Family Health Teams of Ontario. We wanted to allow as high a number of participants as possible, so we're actually holding the same webinar for 3 different groups over the course of the day. So you're actually the last group. We've done 2 such webinars today already. So this is obviously the one for AMHO and CMHA members. And I want to once again recognize the leadership of the CEOs and their teams of the associations for really guiding us through this process, and also staff from a number of the member organizations who actually provided input to make sure that the content was highly relevant for you. So now I'm just going to take a few moments to go over the purpose of and the agenda for today's webinar. The first webinar, for those of you who participated, was really an overview of health policy in the health system in Canada and Ontario. It was designed to provide foundational knowledge that leaders need to make decisions day to day. The second webinar really builds on that first webinar and takes a much closer look and a deeper dive into Ontario's health policy and political dynamics and the healthcare reforms that are underway, such as Patients First and some top-of-mind topics like integration. We're very mindful of the fact that we're having this discussion just over a month before Ontario goes to the polls. It's a time of uncertainty. It's a time of where there is going to be a lot of fluidity in the political environment. In any case, we hope that you come away from today better prepared for change, and also with an understanding of how your organizations can actually advance positive solutions through a time of change. We'll be sharing information about the key players in the health ecosystem. These are the roles that will persist regardless of any government. The faces may change, but the roles will remain. And also we'll be exploring the trends and challenges that all governments will face regardless of their political stripe. And the last section is really about what each of the main political parties have stated or signaled about how they will address these health system challenges, what's likely to continue, but what changes might happen and what they will mean for your respective sectors. And finally, we'll leave you with some thoughts about how your organization and you as leaders can keep moving forward in an uncertain time and actively participate and actually influence solutions using your expertise on the ground. Now I'm just going to briefly go over the agenda and some logistics. We designed the agenda to be interactive, so we really do encourage people to ask questions, make comments throughout. We found in the first round of webinars the dialogue was really quite useful, and I think people got a lot out of that. So we encourage you to, as we go along, if questions come up, if you have observations you want to share, just use the chat feature and share. We will be addressing questions and having discussions at 3 points in the agenda after each of the sections, but you can ask questions at any time. So just a few logistical things. If you have any technical questions, call this number I'm going to give you in a moment for help. It's 1-888-259-8414. That's 888-259-8414, and reference the webinar ID. This number was provided on your agenda, and you can always send us a chat message if you're having trouble getting through on the number. To ask questions and make comments, we're going to use chat, and the chat feature should be at the bottom of your control panel. You simply click on the plus sign and the word chat will appear, and then you can type in your message. The Santis team will be going through all the questions, and we'll, if we get a lot of them, we'll group them in themes. We'll do our best to answer all the questions we can. There may be some that we can't address, and the associations are committed to putting together a Q&A following the session with all of the questions that came in that we weren't able to get to. And lastly, the webinar is going to be available on the association's websites. I know the first one's already up there. This one's going to be up so you can view it if you missed any of it, or share it with members of your organization who weren't able to join us. So with that, I'm now going to pass it over to Dan to take us through the first part of the agenda.
Thanks for setting the context for today's discussion, Janine. It's a really interesting time to talk about the politics of Ontario healthcare as we sit really on the verge of an election campaign. I'm going to start things off today with an overview of the importance of healthcare as a ballot issue in provincial politics, and talk about the relationship between healthcare and electoral politics. We're then going to provide an overview of the three main political parties and their roles that their leaders and other elected officials play in the health portfolio. When you're trying to advocate for change on behalf of your organization or your sector, or the clients you serve, it's vital that you're able to approach the elected arm of government in a way that appeals both to the broader governing philosophy of the party in power, but also recognizes the personal styles and perspectives of the individuals in decision-making roles. Simply put, people matter, and the relationships that you have with people in the elected arm of government are tremendously important for advancing your objectives. In a ministerial system, cabinet ministers are often given huge latitude to make decisions within their portfolio, even if those decisions are not in full alignment with the Premier. And as we go into an election campaign, it's just as relevant for the health sector to think about the potential ministers of health in a new government as who the Premier is going to be after June 7th. Finally, I'm going to be reviewing in this introductory section the key roles and personnel within the Ministry of Health. Janine provided an overview in last week's webinar about the role that the Ministry of Health plays and the interaction and the dynamics between civil servants, political staff, the minister, and local health integration networks, and how those dynamics shape decision making. I think it's fair to say that under any government, it is the interplay between the Premier, the Minister of Health, and the top civil servants in the ministry that shape the major strategic decisions that are made by a government in the healthcare portfolio. This slide shows some headlines that go back just over the past few years, including a few from just before the last election campaign. What they collectively speak to is a sense, an enduring sense from the public, that healthcare is one of, if not the most important issue on the provincial political landscape. When you poll people and you ask people, you ask people in Ontario, what are the most important issues that they deal with in the province? The two things that they report back on are healthcare and the economy. Usually with healthcare as the top concern and the economy second, although that dynamic tends to flip in times of recession or economic distress. The thing about healthcare is that it's appreciated by political actors that governments don't tend to win campaigns on healthcare, although they can certainly lose them. And healthcare is, of course, one of the biggest things that provincial governments do. It's almost half of the budget for program expenditure, over $50 billion. But more importantly than that, it's something that directly and profoundly touches everyone in emotional ways. This leads to a dynamic where each provincial election campaign becomes, in a way, a mini referendum on the incumbent government's performance on the health file. And you certainly saw that back in 2003 when widespread dissatisfaction with the Conservatives' handling of the health file under then Premier Mike Harris was a major catalyst in the election of the Liberals and Dalton McGuinty. And there's a question whether you're seeing this dynamic emerge again. As noted, healthcare is remarkably personal. People's views are informed not just by the media stories and the news articles they read, but by their direct personal experience and the experience of their loved ones and families and friends, interacting with mental health and addiction services, home care services, primary care services, the 2.5 million people a year who rely on emergency departments. These experiences together help people generate a feeling about whether the healthcare system is working well, and importantly, whether things are getting better or worse within the system. Now, for the party in power, in this case, the Liberal government, their job essentially on the health front during a campaign is to remind the public about the series of investments they've made in healthcare and highlight how those investments are improving the care available to the public. That's why you'll probably see a lot of the Premier in coming weeks going community to community, talking about new hospital builds, new long-term care beds, or other investments. The government wants to be able to point at tangible things that they've invested in that people can see as signs of progress on the health file. The job of the opposition is essentially the inverse. They need to argue the case that government is responsible for making the healthcare system work not as effectively, that the government's responsible in some way for breaking the healthcare system, and that the province needs a new hand on the tiller to fix things. That's why right now you see the NDP and the Conservatives talking so much about hospital overcrowding and hallway medicine. And in recent days, some of you might have even seen some election ads really highlighting these issues. What's notably absent in these political discussions around election time are concrete and detailed discussions of a comprehensive plan to fix the system. And former Prime Minister Kim Campbell is famous for remarking that an election is no time to discuss serious issues. And in healthcare, she's spot on. Opposition parties who might have a very, very different view on how to manage the healthcare system still usually confine themselves during the campaign period to general discussions on how they'll fix the system or clean up the mess of the government. And while they're happy to talk about some of the new investments they might make in the system if they're elected, those opposition parties will generally shy away from raising any bold or controversial ideas that could spook voters. And that's due to the fact that for all the flaws in the Canadian healthcare system, as we mentioned last week in the first webinar, Canadians generally express a very high degree of satisfaction in the overall model of the Canadian system and believe that the essential elements are worth retaining. When it comes down to it, very few Canadians or Ontarians are looking for massive disruptive change into the health system, and the political discourse reflects that reality. So just a reminder, the provincial election date is June 7th, 2018. We're entering into a bit of an election season. There are also municipal elections scheduled for this fall, with a federal election next year. As we talked about in last week's webinar, both the municipal and federal governments also play key roles in the healthcare system, so it'll be worth you as health system leaders continuing to pay attention to those evolving electoral dynamics, not just provincially, but also at the municipal and federal level. So to kind of put things in context of a little bit of recent history and where things stand, the Liberal Party has been in power for 15 years in Ontario since winning a majority government in 2003 under then Premier Dalton McGuinty. And for most of that time, they've had a majority government. Majority government essentially means that the party has over 50% of the seats in the provincial legislature and can therefore control the entire legislative and executive agenda of the government and can implement the agenda that it was elected on with relatively little obfuscation from the opposition. In a minority government scenario, as was experienced in Ontario from 2011 to 2014, the governing party has less than 50% of the seats in the legislature and is reliant upon support of one of the opposition parties for continuing to govern and pass essential pieces of legislation, such as the budget bill. So minority governments are inherently unstable, unpredictable. In Canada, they've tended to have a lifespan. I think the average is about 18 months. So the one in Ontario that lasted for 3 years was in some respects a bit of an anomaly in going on for that long. And as we think about potential election outcomes, we need to consider both the possibilities of majority governments and a host of minority governments. One thing that's clear is that organizations need to understand and prepare for change in the political system. However, the trends and realities that impact healthcare transcend political parties, election campaigns, and ideologies. The basic undercurrents of change in healthcare are ones that governments of any stripe need to respond to and tackle. And you need to keep that in mind through the often heated rhetoric of election campaigns. And in the next section of this webinar, Janine's going to talk about some of those kind of enduring trends that all political parties have to respond to. It's also worth keeping in mind that Ontario has tended to favor incremental change over big bang change in healthcare. The final thing I'd like to note is that those of you who've been reading the newspaper recently might think that the election is heading towards a predetermined outcome, and that really we can just fast forward to June 7th and look at a potential conservative government. But I'd just like to note that around the world, over the past 5 years in particular, polls have been notoriously unreliable, and the election democracies have been characterized by a huge degree of electoral volatility, often with significant vote swings in the last days or hours of election campaigns. And very few analysts correctly predicted the Brexit outcome in the UK or the Trump election in the US. Or closer to home in 2014, the unexpected surprising majority win by Kathleen Wynne over Tim Hudak and the Progressive Conservatives, who appeared to be heading to election victory until the final days of the campaign. So I'm just going to give an overview of the key figures from the perspective of the healthcare system in each of the three parties and the roles that those individuals play. So the Premier, as everyone would know, in Ontario is Kathleen Wynne, Premier since 2013. Regardless of who is Premier, however, the person occupying that chair has a few key essential roles in the health system. They select the Minister of Health. The Minister of Health is directly accountable and reports to the Premier. The Premier also sets the mandate for the Ministry of Health and the strategic priorities, most recently through a publicly transparent mandate letter that outlines the priorities of the ministry. And the Premier and the Premier's office provide strategic oversight over the health portfolio, and come budget time especially, they try and balance the healthcare the needs of the healthcare sector against the investment priorities of other sectors. The Minister of Health, who currently is Dr. Helena Jaczek, is responsible for the day-to-day oversight of the Ministry of Health and ministry performance, and is the final decision maker at the Ministry of Health. It's worth noting that Dr. Jaczek is the current health minister and would only be returned to that portfolio if the Liberal government were to win the election in June. Even in that scenario, the Premier would have the opportunity to appoint a new cabinet, so there's no guarantees that Helena Jaczek would continue to be the Minister of Health, although all indications from government are that there's higher degrees of satisfaction with her job performance. Switching to the Conservative Party, the official opposition, with the second most seats currently in the Ontario legislature. The leader of the party is Doug Ford, who just recently won an election contest, quite surprisingly. Again, many of the polls and the pundits would have suggested that Doug Ford had no chance to win the leadership of the Progressive Conservative Party. Many within the party were projecting a win by Christine Elliott or Carolyn Mulroney. So Doug Ford kind of came out of the blue from third place to win that to win that leadership campaign and replace Patrick Brown, who was forced to step down in the wake of a recent scandal. Now, Doug Ford is running not just to be the Premier of Ontario. He's also running for a seat in provincial parliament to represent the community of Etobicoke North and get a seat in the provincial legislature. If the Progressive Conservatives were to become the elected government, it's fair to ask, well, who would they look to become the new Minister of Health? And often in these situations, parties look to the individual who has the most kind of up-to-date knowledge and expertise on the file. And that's often the health critic. Now, the role of a health critic in opposition is to really raise issues and concerns about the government's handling of the health file and try and shift public support away from the government. Importantly, they also advocate for those who feel that their voice isn't reflective in government and don't agree with the policy direction of the government or government agencies. And that's the role that Jeff Urich has been playing. Jeff's a pharmacist from rural Ontario, and he would be well positioned to play a key role in the health sector, potentially as minister in a new government. There's also quite a lot of speculation that former PC health critic Christine Elliott, who ran for the PC leadership, would be ideally positioned to become a health minister under a future government were the Ontario PC party to win the election on June 7th. Switching to the NDP, the NDP currently has, the third most seats in the legislature. They're headed by Andrea Horwath, who is the most seasoned of all of the political leaders, and that this is her third election campaign. The challenge that the NDP has had throughout her tenure is translating what seems to be a high degree of personal popularity into electoral support come election time. So there's been a kind of gap, if you will, between when people are polled and asked who they like in terms of the party leaders. Andrea Horwath does quite well, but that popularity doesn't translate into concrete support at the ballot box. So we'll see if that dynamic changes in this upcoming election. The key MPP or elected official from the New Democrat Party on the health front is Frans Jelene, who's the health critic, longtime health critic for the past decade. Frans represents the riding of Nickelbelt up near Sudbury, and she comes from a healthcare background. She was an executive in a community health center, and really has gained kudos from a lot of people in the system for understanding healthcare decision-making dynamics in the community sector in particular. Last week we talked a lot about the interplay between the federal government and the provincial government and how those evolving dynamics shape how healthcare decisions are made. And we just wanted to note that, there is, as mentioned, a federal election next year as well. But this federal government has been much more actively engaged in the healthcare file and working with provincial governments compared to the previous federal government, and that's in part because of a more activist social policy leaning. So in areas like the health accord, the legalization of marijuana, dealing with the opioid crisis and medically assisted death, there's been really a need for close collaboration between the federal and provincial governments. And the question is, what would happen if the government in Ontario were to change, if the Conservatives or the New Democrats were elected? Would that change the dynamic between the federal and provincial government? For most of Ontario's history, there has been a different party in power provincially and federally, and the conventional wisdom used to be, anyway, that having a party of a different political stripe at the provincial level made things was good for Ontario, that your provincial government representative could fight with elbows out a little sharper to represent the interests of Ontario with their federal colleagues. So it'll be interesting to see how that dynamic plays out going forward. Okay, shifting gears a little bit to the Ministry of Health and Long-Term Care. The civil service is sometimes referred to as the permanent government. It's there, it remains in place. Largely free of the day-to-day political concerns. The role of the civil service is to be politically independent advisors to government, to implement government policies without prejudice, without partisanship, and to operate government-run programs. The Ministry of Health is the key kind of civil service arm responsible for oversight of the health system, and as might be expected in an organization that oversees $50 billion in expenditure and 40+% of provincial government expenditure, it is a very large and complex organization. Just on this chart that you can see here, which you might not be able to read, there are 94 executive roles identified. And it's worth noting that the complexity of the Ministry of Health, the size and complexity of the executive team in the Ministry of Health has really, it's really evolved over the past number of decades as the health portfolio has grown. If you look back to when LHINs were created, the expectation was that the ministry would actually take on a much smaller role, that it would, that I think the phrasing of the deputy minister at the time was that the ministry would be elevated to a more strategic role and focus on systems stewardship, setting policy direction, standard, and overall oversight and accountability for the system. I think what happened, though, is that there's a recognition in moving to the strategic role that the ministry was at risk of losing a lot of the subject matter expertise in areas like understanding how hospitals function, how mental health programs function, how home and community care functions programmed. So under the tenure of Deputy Minister Bob Bell, the ministry's moved to basically rebuild a lot of those program area program areas within the Ministry of Health, while still also retaining oversight for system strategy, policy, and accountability, which has led to some of the complexity and that you see within the ministry organizational structure. I think that how the deputy has tried to manage, this very high number of very important departments across the ministry is to create an executive leadership team that really centers around 3 associate deputy ministers. Laurel Taylor in the center, her portfolio is perhaps the easiest to understand, being responsible for information technology, information management, and all things related to eHealth and liaison with the eHealth Ontario agency. Sharon Lee Smith, the associate, notionally her role is more focused on system strategy, policy, and transformation, whereas Nancy Naylor is responsible more for delivery, implementation, and accountability. However, if you look at some of the programs embedded underneath their areas of responsibility, the specific ADM level, and then even more at the director level, you'll see that some of the actual functional programs, and we're talking about like oversight of the hospitals, home and community care, primary care, and mental health and addictions, are actually kind of split between these portfolios. And for the folks in this webinar, it's worth noting that Patrick Mitchell is the director of the Mental Health and Addictions Program and fits under that larger portfolio that Sharon Lee Smith oversees. I just want to provide a case study here where we to talk a little bit about the dynamic interaction between the civil service and the political decision makers within government. And we recognize here that we're not providing an example that is directly relevant to you. This is more illustrative of the ongoing tensions and decision making processes within government. So we're just going to talk about the allocation of the first 200 family health teams that were created in the province of Ontario. So when family health teams were created, there was a recognition that there was not enough primary care capacity in the province. There were the OMA was estimating that there were about 1.5 million people in Ontario that didn't have access to basic primary care. And the governments ran on, in 2003, the Liberal government ran on a commitment to introduce interprofessional family practices to really be able to increase the ability to service people and address the physician shortage in primary care. The Ministry of Health, after the election, was tasked with coming up with a strategy for implementing this political commitment. And they really came up with the family health team model to large degree, how it would work, how it would be funded. They also did the community by community analysis to determine where family health teams should be located. But the ultimate decision about where those family health teams were approved was up to the Minister of Health as the final decision maker. And the Minister of Health had to overlay on that technical expert advice provided by the ministry, the input from his colleagues at the time, members of caucus, who would often raise concerns about the level of the lack of access to primary care services in their community. And based on that level of community concern, the emotional concern that people were communicating, that had to be compared with the more fact-based, technical analysis provided to the ministry, which ultimately resulted in the location of the family health team spread across the province. So it's an inherently political process informed by the expert advice of the civil service. So I'm going to pause there and turn it over to questions.
Okay. Hi, everyone. Looks like there aren't any questions yet, so we're just going to keep going, and I will be pausing after my section. So the next section is really about the trends and system drivers in Ontario that really transcend any one political party or government, that any government's got to pay attention to, and you as decision makers will need to keep your eye on. There's a lot of things going on, and it's important to kind of zero in on what are the most important things. So here's our take on the most important realities. Before I get into the specifics of these trends, I wanted to just take a few moments to put health reform in Ontario into a broader context. When you're in the midst of going through a time of reform, it can feel like the transformations are something brand new, that what you're undertaking is really a departure from the past. But really building on what Dan was saying, over the last couple of decades, Ontario has really tended to favor incremental change. The pace of change is faster than it used to be, but we haven't seen any really wholesale overnight system changes the way you have in other jurisdictions and countries. And there is actually more consistency between the way in which governments have addressed challenges than people actually think. And some of this is because the latitude for reform is constrained by our model of Medicare. The Canada Health Act and other legislation really does determine what is funded by a public system, what provinces are allowed to do, and so in that some ways has led to this incrementalism. Patients First is the current government's health reform plan, and many of you would be familiar with it, and I'm sure are participating in a number of initiatives related to Patients First. Some of the, we should think about Patients First as really the latest policy response to trends and issues that have been with us for a long time. Some of these developments may be more urgent today, but they're not brand new. I want to highlight a few milestones that have really led to where we are today. So I'm going to start back in 1974 with the creation of the district health councils that many of you will remember. They were created by the PC government under Bill Davis, and really what's important with that is that they were the first the first policy to really devolve planning to a more local level and start to design health services around the needs of populations within geographies. The DHCs were planning and advisory bodies, but they didn't have power to make decisions or actively manage the healthcare system. Another key milestone was in 1987 with the Ontario Health Review Panel, so-called Evans Report, and this report was essentially about care integration and how to reduce silos between the different parts of the system. And I think it would be interesting when you have some spare time to actually read that report to see if it's relevant today. Over 20 years ago, the CCACs were created under a progressive conservative government, and they were created as a way to organize and standardize home care services and also to manage the costs in the face of a growing seniors population who were requiring more care at home and in the community. Initially, there were 42 CCACs, and they were tasked with coordinating care at a much more local level than they do today. Around the same time, the government also created the Health Services Restructuring Commission. And really the main impetus for this was the government faced mounting healthcare costs and pressures, and they wanted to really get a handle on the overall provincial debt. So the hospitals, being the largest expenditure, were really the target for really trying to reduce the cost curve in healthcare. They felt that there was too much duplication and silos between the hospitals, and they really were ripe for rationalization. So hospital mergers became the key mechanism to create this more efficient system. So the HSRC was created as kind of a third-party commission to recommend a healthcare restructuring plan focused on hospital mergers. But also there was a desire to deliver more care in the community and home care. So really push community and mental health care from hospitals into the community. At the end of the HSRC's work, after the recommendations, the government acted on many of them, and over 25 public hospitals were closed. This was very dramatic in terms of disruption, but it didn't result in fundamental changes to the way healthcare was delivered. And a critique at the time was that this hospital restructuring was not accompanied by an investment in really a development of services outside the hospital, namely community mental health and primary care. So fast forward to 2006, and the government created the LHINs, and because they recognized that there needed to be a more effective model to manage the system, it was very hard to do centrally because of the size and complexity of Ontario's system, and they wanted to follow suit with other governments that have looked to regionalize healthcare as a way to better manage the healthcare system and make it more responsive to people's needs. The whole idea behind the LHINs was to give local providers more accountability for healthcare solutions that work in their communities on the ground. And LHINs were created as the agencies who would be tasked with looking at the needs of the system as a whole, so not beholden to any one service provider or sector, but really look at the system in its entirety. There was a debate from the beginning about governance and who should set priorities, who's really should be accountable for managing the system, and we talked a bit about that in the first webinar. But it's important to emphasize that Ontario's model purposefully retained provider boards, so that the reason being is that this would allow there both to be kind of top-down direction from the ministry and through the LHINs in terms of direction, in terms of the system, but also an ability to enable bottom-up problem solving and accountability. Now with the subregions, there's a lively debate about governance once again, and that will continue. And the question will be how much control the LHINs will have, how much accountability will be devolved to providers. And one shift that is happening and is most likely to continue is that there's a real move to providers having shared accountability and mutual accountability for one set of outcomes for the population. So we're going to see moves toward providers having agreements like MOUs between them to agree on delivering a certain set of services at a certain level for populations, and even moves to having funders having single accountability agreements with a group of providers rather than one-off agreements with each provider. So next slide is just focusing in on the current reform strategy. You know, Patients First really does build on past reforms, not only of the Liberal government over the last 15 years, but those before it. But there are some different aspects, and I want to focus in on them that are really relevant to your sectors. It's built on 5 proposals, and I'm going to really just focus on the ones that are of most relevance. The first one is the government decided to devolve healthcare management to even more of a local level with the creation of subregions. So LHINs are responsible for creating subregions, which are basically networks of providers from all sectors who come together in a small geographic area to provide care in a coordinated way. Each of the LHINs has roughly about 5 subregions in their areas, and they are comprised of providers across every sector: hospitals, community providers, community mental health. And in fact, in many of these subregions, individual agencies or provider organizations are playing critical leadership roles in deciding the kind of the priorities and providing new novel coordinated care models for local populations. The second priority is really creating a better integrated home, community, and primary care system. So really bringing together those services at the local level. Part of that is the CCACs merging with the LHINs, so some of the the home and community care roles, like the care coordinators, being brought into the LHINs, and that is supposed to be a way to create better linkages between all the community-based services that have worked kind of in a siloed way. And the other big change is that the LHINs have clearly been asked to take on an expanded mandate. We'll have to see how that unfolds, but the intention is that now LHINs, with having taken over the CCAC roles, are both in charge of planning and overseeing community-based services, including mental health and addictions, but also delivering some of those services, including the critical care coordination service that the CCACs provided. The other thing that the LHINs have taken on is they're now responsible for planning primary care, so looking at how primary care will be services will be aligned and integrated with the rest of the system. This is a challenge for the LHINs because, of course, they don't fund or have authority over most primary care. So we're in the midst of an uncertain political situation, as Dan has outlined, and we don't really know what's going to happen. And even when the election does happen, it's going to take a while to figure out what the kind of the policy implications of that are. But a few things just to observe is that our healthcare model is deeply institutionalized and entrenched, and it's not going to be easy to change. And there's no signs that the public wants any major disruption of the healthcare system. In fact, quite the opposite. What people do want are improvements, but they don't want a wholesale change. What we might see is some changes in some areas that would affect you, meaning what is the level of funding increase that the government will commit to? Will there be base increases or not? And what will each government prioritize? They will each target funding in different ways, but don't expect a revolution. So a little bit later on, we're going to talk more specifically about how healthcare providers can keep moving forward in this kind of ambiguous time. What we do want to continue to reinforce with you is don't get caught in waiting for top-down direction, because we do have a system right now that does allow for a certain level of innovation and solutions from the ground, and that's what you have been doing as sectors, stepping up and coming to the table with different kinds of ways of working together and delivering services. Keep doing that. And if there are disruptive changes in some areas, this actually can be an opportunity to put forward solutions that you believe will improve client care. So now I'm going to go over what we think are some of the key trends that you need to be watching for. The first one is this shift toward focusing and funding based on outcomes, not simply outputs or activity. So historically, healthcare services were funded based on the number of activities or volumes. But as we've gotten better data and better evidence, we realize that providing just more and more services, or providing services using traditional models, doesn't necessarily translate into better health outcomes for the population. Plus, funding activities is really hard. It's really hard to manage costs. Funding volumes and funding historical activities is really an incentive for providers to provide more and more activities, but not necessarily to improve health. So over time, there's been a move toward expecting outcomes for funding provided. And this change has gone hand in hand with having better information and greater capacity to actually use evidence to assess whether we're doing the right things and whether the things that we're doing are actually not only improving health, but the experiences of clients and communities. The Excellent Care for All Act, which was passed in 2010, was an important platform because it gave a basis for government, LHINs, and funders really to stop paying for things that either the evidence showed were not improving quality of care, or where funders were paying too much for the outcomes received. So there's a number of different examples of this, but one that got a lot of attention was that government there was a decision to stop ensuring funding vitamin D testing based on clear evidence that vitamin D testing was not a benefit to the population. In fact, it was leading to overuse of vitamin D. There's many examples in the ministry and the LHINs where they are starting to look for proof of outcomes for funding. So the LHINs accountability agreements, for examples, they're shifting from asking HSPs to be accountable for volumes to meeting outcomes-oriented metrics. In the primary care space, there's been an incremental move away from a fee-for-service model where physicians are reimbursed based on churning through as many patients as possible or the volume of services, to really a capitation model where they receive funding based on the number of patients. So the incentive with a capitation model is supposed to be to provide more comprehensive care rather than just simply more services. This next example here is bundled care. So the Ontario government is really starting to experiment with some innovations in how they fund services to get better outcomes. Funding reform that's being undertaken in Ontario will impact all sectors. Started with hospitals, but now the community sector is actually participating in some of these models. So now they're testing so-called bundled care payments. And what this is they're starting to fund services that are provided collaboratively by hospitals and community agencies together. So groups of hospitals, home care agencies, community agencies are coming together and receiving funding to support the patients to transition from hospital back to home and into the community. So they're sharing this funding to provide a whole continuum of services to get really to support patients to get out of hospital and get back home safely. There's some thinking that the LHINs want to move actually toward more standardizing what they pay for certain community and mental health services. So this would mean that they would move to paying providers or a group of providers for a service at a certain standard for a certain price. So they're going to focus on services where there's variability in terms of what the LHINs are paying different providers and where there are clear gaps or inequities in terms of populations receiving services. So you may have be aware of conversations about kind of more standardizing the way mental health services, for example, community mental health services are paid for, but that is likely to be a trend that we'll continue to see in Ontario. The next trend is cost containment and continued search for efficiency in the healthcare system. We talked a lot about the last webinar how Ontario has really constrained spending for most of the last 8 years or so. And in fact, Ontario has had among the lowest per capita spending on healthcare of any of the provinces in recent years. They have really only increased funding to about between 1% and 2%, which is barely keeping pace with inflation. Although what they have invested in to some degree is community and primary care, and they've done that as a way not only to improve outcomes but really because they know that they need to shift more care. Everyone knows that we need to shift more care into the community and primary care in order to reduce costs to the system. So there's been about a 6% increase in the community sectors overall in recent years. Of course, you know that this funding has not been base funding increases, and some agencies have not felt the increases at all. The increases have gone to expand services and mostly to support new programs and models, but the funding has not gone to meet current increases in demand or the operational pressures that you're already feeling every day. And also there is a general recognition that the investments may not be enough to keep pace with the influx of additional clients who are receiving care in the community and community mental health rather than hospital. So in the community sector, necessity has really been the mother of invention, and the fact that there's not been any major reductions in services or over the last number of years is really because your organizations have been very creative in terms of finding ways to be as efficient as possible as organizations and as sectors. And at the same time, government, LHINs, and providers have together made significant changes in how you organize and deliver services. So we're seeing now more sharing of resources across organizations, such as back office services. We're seeing providers join with others who maybe have different capacities that they need, different expertise. And we're seeing more interdisciplinary and team-based care being delivered across all sectors. But it's becoming clear that the system, we may have reached the breaking point in terms of finding efficiencies within organizations and within sectors. And in fact, if community agencies were any leaner, some of them would simply be unable to operate, and this would have a very negative impact on client care. The province's own Financial Accountability Office actually just released a report, and they said that healthcare funding is not keeping pace with demand and that it could compromise quality if it's not addressed. So not surprisingly, the government has announced a pretty significant increase in healthcare funding for hospitals and the community sector. And what is really most interesting is they announced the first base funding increase in some time to meet this pent-up demand in the system. But I don't think any of us should expect that we'll go back to the spending levels in healthcare that we had, decades ago in the double digits. And another important trend that will persist is that everyone realizes that we can't meet the needs of the population by acting in isolation, that providers will need to continue to share resources and find collaborative solutions, and also that strong, well-coordinated primary care and community care is really the only path to not only improving population health, but making the system sustainable. The third trend we want to touch on is, we're going to continue to no doubt see healthcare delivery shifted out of hospitals and institutions and into the community and primary care sectors. And we're going to see a reduced reliance on hospitals. You may wonder if this trend will continue, because there's been a big focus in the media on hospital crowding recently. There's been recent announcements about significant funding in hospitals. So it may seem like we're kind of shifting to the past and really shoring up hospitals again. But I think this is really a reflection of the fact that, government is maybe realizing that hospitals have maybe been squeezed a little bit too much in recent years. They've had flatline budgets for a number of years now, even while the community sector has seen some investment. So really this recent investment in hospitals and in community is about recalibrating things. But we don't, because government doesn't want the quality of care in hospitals to deteriorate. But nobody thinks that this is really going to alter the course, the overall course of reform, which is we're going to continue to see a strengthening of care outside of hospitals, including community mental health. Another important trend to flag is that hospitals themselves have been taking leadership role in shifting care into the community and actually creating strong communities of care, if you will. They know that a strong community care and strong mental health is key to their own sustainability and better for clients and patients. And hospitals have something to bring to the table. They have infrastructure, they have a lot of capacity and expertise to support the development of coordinated service networks. So some hospitals like the Sinai Health System or St. Joseph's in Hamilton have been playing a lead role in creating really a continuum of care that brings together acute care, rehab, but also home care and primary care for a defined population. There is, of course, different views about whether hospitals are best positioned to create integrated community-based systems. And really, there's also evidence that better results come from community, primary care, hospitals, and others actually co-leading and co-creating these interconnected systems of care, because each sector has its own strengths to bring to the table. Hospitals bring infrastructure and different kinds of maybe management expertise and capacity. Communities bring a deep knowledge of their communities and clients, and they understand the social determinants of health in a way that perhaps the acute care sector doesn't. So the approach of bringing all these sectors together to co-create solutions is really the model that's being unfolding in the sub-regions within each LHIN. The fourth trend is more decision-making being based on data, and digital health having a key role in really creating integrated systems. So having good data, having information systems that enable providers to share client information, to plan services, to measure and improve performance, these are all, of course, crucial to high-performing health systems. Ontario's had a mixed experience so far with digital health and data. On the positive side, within sectors, there's been significant investments in innovations, and your own associations have played a key role in attracting investments to really build capacity around data use and management and performance measurement. The LHINs have also driven initiatives to really try and link data between sectors. And we certainly have a much better ability to gather data to understand the needs of populations and health services and really understand those needs at a very local level. The adoption of electronic medical records within primary care is pretty high, so the vast majority of primary care have some access to electronic medical records, which is a positive. But really, we still don't largely have the ability to share client records, to share information seamlessly and consistently across providers and sectors. It's really difficult still to link information to manage care across the continuum. And you would experience this in a very real way every day as you try and provide a coordinated care to your clients. And we're also behind in Ontario in terms of engaging clients in using digital health and technologies. One of the metaphors for how siloed digital health really is in Ontario still is the example of patient portals. So hospitals have really done a lot of work on creating these patient portals for their own patients. So the idea is to bring together information about the patient's services and care related to that one institution. But what's happened is patients have actually multiple portals with each of the organizations that they receive care from. So each of these portals provides just a slice of information about their care with that one institution. They don't have one place to go where that brings together all their health information together in one place. So as a consequence, some patients don't even use these health portals because they find them too confusing and unwieldy. The fifth trend is an emphasis on population health management. This is a very positive development in the healthcare system that really is an opportunity for community mental health to really take leadership. Because what this means is healthcare systems, and you'll see this, the LHINs are moving to this approach, but the subregions are really looking at the, organizing care around populations. This means looking at how to improve the health status of an entire population, and included in that is reducing the inequities in access and outcomes between different groups in the population. And this is really aligned with the philosophy of your sector, where upstream, you've been making the case for some time that upstream investment in prevention and support services really has a benefit in terms of people's overall health and frankly health outcomes and costs downstream. But as you know, it's been hard to get traction and investment in more preventative health services, more community-based health, let alone addressing the social determinants of health. And the main reason for that is because people intuitively believe that investing in things like prevention and supporting people to be independent and recover from mental health challenges is beneficial and actually will produce better outcomes down the road. It's been hard to get the proof that investing in these services directly links to better outcomes and cost savings. So having more interconnected data will allow us to show the cause and effect of some of these investments, and you'll be able to build better business cases for investing in preventative health care and the things that really will improve population health. So the last trend is probably the one that's on the top of everyone's mind, which is integration. And there's a lot of talk about what integration means, and there's a lot of different perspectives and a lot of work going on to figure out how individual organizations can actually use integration as a way to improve health for your populations. It's fair to say there's interest, but there's also a lot of confusion and some anxiety around the topic of integration. But integration is really something that every system, health system anywhere has had to address. This is just the basic idea that no one part of the system can provide all of what people need alone. In Ontario, there was a realization that, people are getting high quality care and their experience is favorable with specific services when they have an interaction with one provider. But it's the movement across the system, it's the care transitions that don't work as well, and that's where there's the greatest dissatisfaction. So Ontario has put integration front and center as a mechanism to achieve better quality, but also a seamless experience and hopefully more cost-effective system down the road. And the LHINs were created as a model to create that integrated system. So the LHINs are, because they're kind of a separate entity that isn't, they do provide some services now, but they're mostly, have oversight of all services. They're looking at the system as a whole. They're not looking out for the interests of any one provider, any one sector. That's the way the model's designed. The patient's first strategy emphasizes integration as well, so integration between primary care and community, integration between mental health and home care and community support services, and importantly, integration between health and all of the non-health providers that actually impact people's health, such as social service providers, municipal services, cultural services. What's really important to understand is that integration was never meant to be an end unto itself. It was rather a means. It's a strategy. It's one strategy among many strategies. And the other thing that is important to understand is it is very unlikely that the government or the Ontario will put the brakes on integration. The question will really be how integration is driven, how much top-down direction there'll be around integration, how much freedom providers will have to bring solutions up from the ground, and what will be the speed and intensity of integration. This next slide is really meant to capture a common kind of definition of what integration is, sort of a textbook definition. But I do want to say that Community Health Ontario, which is the umbrella group that brings together the OCSA, AMHO, CMHA, and the AOHC, put out a paper on integration, and we are going to put it up on the portal for these webinars so you can see it yourselves if you haven't read it. But really it is very, I think, a very healthy perspective on integration, because it talks about really the goal is about creating an integrated experience for the client. It focuses less on the how and why and the why you're integrating, and really the strategies that you choose should be all about how do you improve the experience and the outcomes for clients, and how do you take a proactive approach to looking at the best strategies for integration. This next slide is taken from a report that the Toronto Central LHIN did, but I think it's relevant to any LHIN anywhere in the province. The Toronto Central LHIN did a review of its role in integration and created a framework and a toolkit back in 2016. This was created by Optimus, which is a consulting group, but really it shows that integration should be seen as a spectrum of activity. Often when people think about integration, they go directly to mergers and structural integrations. And yes, mergers and structural integrations are part of integrations, and they do have a place. But there's a whole range of activities that are integrative in nature that should be considered integration. And in fact, there's a lot of things that you do every day that are in fact integration. You may not be thinking of it that way. And there's a lot of activities that come from, that are led by providers that really the LHINs are not really involved in overseeing or approving at all. So we encourage you to think about integration broadly. So I'm just going to go through this spectrum. So on the far left side, integration can range from having informal networks to share practices like communities of practice, having a one-time arrangement around a particular service. It can be formalized partnership agreements, so agreements on referrals or taking common approaches to populations or aligning planning. It could be creating standardized pathways and including coordinated access model. So many of you probably participate in these in the mental health and addiction space. So that includes coordinated intake, having common referral processes, common wait lists, and then all the way to merging programs and services through to full integrations where boards and organizations actually fully integrate and become one entity. Regional health authorities in other provinces are probably the most extreme version of an integration, where they actually have one healthcare provider under one board responsible for delivering a whole continuum of services for a population. So many of you while you're participating in a lot of integration type activity, you're also trying to look more formally at where and have a more systematic plan for how you pursue integration in a way that supports your clients and actually will be ultimately a benefit to your organization, clients in the system. The starting point for thinking about integration should always be being very clear on what you're trying to accomplish. What are the objectives you're trying to achieve? Form should always follow function. So sometimes the impetus will be you want greater financial sustainability and you need to join forces, or maybe, you know, merge your back office, some of your back office services to maintain financial viability. It could be that you want greater capacity in an area where you don't have capacity, so you want to join together and partner with an organization that maybe has a better IT system and expertise or other kinds of infrastructure. You may want to provide a broader array of services to your population that you don't have today. The needs of the clients are changing. You want to better meet them. So this next slide is really just a couple of examples on the ground. There's many that are happening where organizations together with LHINs are creating the more integrated health service delivery networks. There's a lot of innovation that's happening. The first one I mentioned early on is the Sinai Health System. So Sinai took the lead as a hospital to create an integrated system really for a particular population, which is seniors with complex needs. So they did that by merging with a rehab hospital, so creating a link between acute care and rehab. They also, in the process, brought on 2 family health teams, and they acquired a home care provider. So now they're providing more of a continuum for you know, patients that are considered medically and cognitively complex. The next one is the Muskoka and Area Health System Transformation. So this was created prior to the subregion. So the North Simcoe Muskoka LHIN created a council that brought together health service providers, municipal leaders, social and community services, everyone around one table to create a single plan for providing health care to the population of Muskoka, so including Bracebridge and Huntsville. This was an ambitious project, and the work that they did together, the planning work and the partnerships that were created, will now really be taken on by the subregion. So the area, the planning area, actually is the subregion for Muskoka. So now that subregion has a really great head start to create an integrated local health system or network. And the last one is the government has taken a real interest in enabling hubs, community hubs that bring together different sectors to make it easier for people to get all of the services they need in one location. Some of them are co-located. They're hubs that bring together services in one place. Some of them are, you know, physical locations with some virtually connected services, but the idea is to create more seamless access to services for populations. So this is just one example where the government announced in February of last year the creation of integrated service hubs for youth. And these one-stop shops, if you will, bring together not only health care services, but education, employment training, and a number of other social services needed particularly by high-risk youth. So the last piece I want to leave you with is really doubling back to the role of the LHINs, because the LHINs, it's in their name, they're really the entity in the healthcare system that's really tasked with leading integration in the healthcare system. And you know, it's important to know that their powers around integration are embedded in their legislation and always have been. And there's really 3 ways that they can really advance integration. The first is using funding to incent organizations to integrate services. So more and more you're seeing that LHINs will use funding, for example, to decide, targeting funding to decide what they will pay for and what they won't, and more funding, more often than not, they're looking for collaborative solutions. So they're no more are they giving individual organizations funding for projects or services, but they're looking to organizations to bring a collective solution that they will fund. LHINs also have the ability to be more directive when it comes to integration than they perhaps have. They do have an ability through legislation to actively facilitate and negotiate integrations that they think are in the interests of the healthcare system and the population. And the last one, C, is voluntary integrations. And these are integrations that are driven by providers themselves. And most of the integrations that have occurred have been voluntary integrations. The LHINs will often encourage voluntary integrations, and they will oftentimes help assist organizations going through voluntary integrations through things like some LHINs will provide one-time funding to help cover some of the costs of integration, such as legal support or project management, and they will often provide guidance and tools to help organizations integrate. But there's still not a lot of evidence in terms of whether what more support the LHINs could provide, or whether or how the voluntary integration experience is going. And now with the subregions, the focal point for integration will be on these local levels. So integration of providers across sectors in geographic areas. One of the things, many of you are probably sitting at sub-regional tables. Some of you may be playing a leadership role. So you do have actually an opportunity to shape how these sub-regions will actually operate on the ground. And some of the things that has been talked about is actually formalizing the networks within a sub-region by maybe appointing lead agency or lead agencies, or actually having the ability for providers within an area to actually determine and allocate funding for services in their area based on the needs of the population. So this is really a time, it's early days, for agencies themselves to get involved with subregions and actually be part of the conversation and help to shape how these models will unfold. So now I'm going to open it up. There are some questions here, and that's great. The first one is on supportive housing. Who has oversight for supportive housing? There's actually 3 parts to the question. Maybe I'll name all 3 parts, okay? Who has oversight for supportive housing? Is there a cross-ministerial planning? And is there new money for supportive housing? Over to Dan.
So I'll address those 3 questions. In terms of the first part, in the Ministry of Health, embedded in that section that we highlighted that Patrick Mitchell oversees as the Director for Mental Health and Addictions, there's a kind of subsection of his division that focuses specifically on housing related to mental health and has thematic responsibility or programmatic responsibility for supportive housing. There's also people at each of the LHINs, though, who have responsibility for supportive housing. So I'm on the board of a supportive housing provider here in Toronto, and our primary interaction from the Ministry of Health side is at the LHIN level. But of course, in supportive housing, there is a lot of cross-ministerial dynamics. Many providers also get funding from the Ministry of Housing or indeed other ministries. And although there's always ongoing criticism about the lack of collaboration and coordination between providers, it is important to note that the ministries in the government do work together. So just last year, the Ministry of Housing, the Ministry of Health and Long-Term Care, the Ministry of Community and Social Services, and the Ministry of Children and Youth Services released what they called a framework for supporting supportive housing for Ontario. There are some investments associated with that, and I think the noteworthy ones in the budget, over the past year, included an announcement in the fall of 2017 where the government committed to 2,000 new what they refer to as additional beds and spaces that included part of that was supportive housing units. It's nowhere near the demand to meet the demand that's required. The other piece that's worth noting, and again, details are very vague, is that as part of the recent budget commitment to $2.1 billion over 4 years in mental health, there's an allocation there notionally to support supportive housing as well. So I hope that addresses those 3 questions. Thanks. I think I'm going to move on to the next section, just given the time, and we'll address any outstanding questions at the end. And we're just going to look ahead to the how Ontario's 3 main parties are approaching the provincial election and what their priority commitments are on the health portfolio. And first of all, starting with the Ontario Liberal Party, is probably the most comprehensive kind of detailed set of commitments on the healthcare side, simply because they're the incumbent government and had an opportunity just under a month ago to table a provincial budget. Now, it's important to note that this budget is really a pre-election communications document, because many of the commitments that are articulated in the budget would only move forward in the case that the Liberal government is re-elected and has the mandate to implement the budget commitments. So this budget, in a way, can be seen as the basis for the political platform that the Liberals will campaign on for re-election. From a healthcare perspective, what's notable is that the budget commits almost 5% in annual increases to the healthcare sector. Maybe, as Janine referenced, still not enough to deal with the surging demand in many parts of the system, but a significant departure from the previous years of 1% to 2% investment, and probably a departure where you'd see the progressive Conservatives in particular go in terms of investment into the healthcare system. A lot of that money that they've targeted would go to the hospital sector, to long-term care, for new capacity, $650 million for home and community care, and as I just mentioned on the issue related to supportive housing, $2.1 billion over 4 years for a whole kind of host of mental health and addiction services, including structured psychotherapy and other supports. So that's not just Ministry of Health funding; that's funding across a number of those portfolios that provide mental health services. In terms of the NDP, the spending plan for the NDP is very similar to that of the Liberal government in terms of seeing a rebound in healthcare spending. And they talk in their election platform about addressing hallway medicine and hospital overcrowding and ensuring that at a minimum hospital spending grows at the pace of inflation. They also talk, interestingly, about putting a kind of system-wide moratorium on layoffs of frontline healthcare professionals until the province develops an integrated health human resources plan. They also talk about the creation of a universal dental and pharmacare program that would offer coverage for everyone. The plan put forward by the Liberals has universal coverage for those under 25 and over 65, but less coverage for those in between 25 and 65. The NDP plan would provide universal coverage, but of a smaller amount of drugs, at least initially. So that the NDP plan is arguably broader, but a little less deep than the plan the Liberals are putting forward. In terms of mental health and addictions, what's really relevant to you folks is that they're calling for the creation of a standalone mental health and addictions ministry that would bring together the programs related to mental health and addictions from across government. That it could include, children and youth services, correctional services, Ministry of Health, and other ministries. There's very little detail about how this ministry would be structured, but there has been long-standing calls from many advocates and many who've studied the issue to better integrate mental health and addictions kind of planning and service delivery, and this is obviously the NDP's response. I think one of the major questions, if they were to be elected, would be how would they create this standalone ministry focusing on mental health and addictions, and not simply create new silos between mental health and addiction services and the rest of the broader health system, and when so many of you have been working to effectively collaborate and integrate with peer organizations that are more focused on, say, seniors issues or primary care services. So this would have to be very well considered and thought through, but they have committed to the creation of a standalone ministry for mental health and addictions. Now the Conservatives are a bit of a mystery right now, because there was a very well-developed policy platform under the previous leader, Patrick Brown. But when Patrick Brown was forced to step down and Doug Ford assumed the leadership, he essentially scrapped the platform that was developed and the 100-plus commitments that included a lot of discussion about the party's priorities in the healthcare system. So until and unless the Conservative Party releases a detailed platform, all we can really go on in terms of their healthcare priorities is their public statements on healthcare, and they've been somewhat there haven't been too many of them, to be honest, over the past few weeks, and they've been somewhat vague. What they have said to date, this is kind of a comprehensive tracking of what we could find of the party on healthcare under new leader Doug Ford, is that they're going to prioritize listening to frontline healthcare workers to find efficiencies and better delivery of services and provide more help and resource to the healthcare system, and that will result in an end to hallway healthcare in hospitals and provide more access to timely care. A lot of that is quite vague, and we'll look for more details in coming weeks over the course of the election campaign. The only issue really where there's been any specifics is earlier this week, Doug Ford announced that if he were elected premier, the government would not be supporting safe injection sites, and they've suggested that the focus on tackling the opioid crisis would be more on improved access to drug treatment as opposed to harm reduction approaches. Again, these priorities are just reflective of statements over the past few weeks since Doug Ford became leader. There is a possibility that the party will put out a more detailed platform that would kind of detail their healthcare priorities, but there's also some within the party, and I think Doug Ford has suggested this himself, that they might not put out a full platform at all and instead might just talk at a higher level about 5 key priorities for governance. So even going into the election, it might be a little bit of a mystery where the party stands on some of these issues. And with that, I'll kind of turn it over to questions if there are any. There's another question about supportive housing, and we're not going to get I'm not going to get into the details of that in part because that's not the purpose of this webinar, which was more to provide an overview of the political environment and how that pertains to the work. Neither Janine or I are experts in the area of supportive housing, although I do have lots of thoughts on that topic from my 6 years on a board in the sector that I won't get into. Are there any others? Did you say, okay, this is a question, did you say there have been base increases for LHIN-funded community mental health and addiction services? I don't know if Janine wants to respond to that. I think the message that I heard in her comments, and I'll let her correct me if I'm wrong, was that generally organizations have been receiving 0 base increases over the past number of years and have only been receiving increases for volume increases or for new models of care. However, there was a departure in the last budget in that the 2018 budget commits the government to ongoing base increases for community mental health providers. But as mentioned, those increases would be contingent upon the government being re-elected in some respect. Janine, do you have any other comment on that? No? One of the questions is there any indication of the Progressive Conservative Party of Ontario's attitude to the LHINs at this point? Prior to Brown, they consistently talked about disbanding them. Yeah, under previous Progressive Conservative leader Tim Hudak, it was an explicit part of their platform that if they got in, they would eliminate LHINs, which were referred to as just another layer of bureaucracy. Patrick Brown kind of walked away from that, and there was no commitment in his platform, which was called the People's Guarantee, to disband LHINs. Although they have talked about reducing efficiency and bureaucracy within the system. Doug Ford has, as far as we're aware, has not commented directly on LHINs, although it is expected that if the Progressive Conservatives were elected, they'd take a comprehensive look at the relationship between the ministry, the LHINs, and the service providers. There's a lot of people in the kind of conservative orbit who've long advocated for a model of almost like hospital hub-based models of integrated care, where under such a scenario, LHINs could theoretically be eliminated, and the locus of planning and organization could be at the sub-LHIN region and organized around hospital capacity. But that's just pure speculation at this point, because Doug Ford himself and the party has really said nothing about the future status of LINZ or what they would do on it, although, as mentioned, we might get more clarity in coming weeks. Okay, another point that maybe Janine wants to respond to, critics argue that there's really no healthcare system at all, just pockets of excellence. How do you expedite rollout of those pilots you mentioned, ensuring portability among subregions and continuum of care?
I think you've really hit on one of, the risks of further devolving healthcare organization to a local level, that while the subregions may allow for some great innovation at the local level, how do you also make sure that those innovations are spread across the system and scaled up to a level where they can create impact? So I think that one of the things I would encourage you to do is you sit at these tables with the subregions, with your sectors, with the LINZ, is to really talk about the platforms for sharing innovations across subregions, but frankly across LINZ, and to make sure that there is also planning and coordination of services across geographies, not just within local areas for certain services. Your associations also have a big role in terms of, making sure that, or in supporting sharing of best practices and spread, so that they don't remain perpetual pilot projects. And I know Ontario is often criticized by having perpetual pilot projects that don't necessarily go anywhere. So I think this is one of the challenges that the LINZ will have, is to make sure that there isn't actually creation of these siloed pockets of excellence, and that we're actually, leveraging good ideas and applying them more broadly across the whole, all LINZ in the province.
Okay, we're gonna wrap up now, and with what you can do in the position of your organization, your leadership position within your organization and within the sector, in what is acknowledged, we acknowledge an unstable environment. There are essentially two ways that you can choose to deal with this environment. You can say, well, things are changing. They're highly changeable, and it's best to just hunker down and focus on our day jobs until we know what the priorities of the government are and how we can respond to them. The challenge is that that means that you're always putting yourself in a position of responding to top-down government policy that might not be incredibly well considered and might impact you in quite negative ways, not just you, but the clients that you serve. Also, in the case of a potential minority government, there could be a sustained, prolonged period of instability during which you don't really fully know what the policy priorities of the government are. The alternative approach that a lot of organizations, kind of leading organizations, adopt is to recognize that particularly during periods of transition and instability, there's almost a unique window of opportunity to help shape and set the agenda. That new governments come in and they have some strategic policy priorities, but they really have very, very little understanding of how to implement a policy agenda and how to translate broad policy goals and objectives into detailed on-the-ground implementation. And that's where there's a real opportunity for leaders within the sector to be able to advance concrete solutions and drive some of the change from the bottom up. And the recommendations that we make to you as leaders within the sector is that you really shouldn't be waiting for permission or waiting for clarity to this. You have an opportunity, leveraging your understanding of the environment you operate within, to collaborate with others, clearly define the value that you can offer, and take solutions to decision makers, the local MPPs that will get elected in your communities, the LINZ and the representatives of the Ministry of Health and others. And by positioning yourself on the side of clients and communities, advancing solutions to address those gaps and those what someone just referred to as the silos between the pockets of excellence in our system, you can help provide the government with answers to some of these complex problems, some of these enduring challenges that Janine talked about in her presentation. there's always the opportunity to leverage your provincial association on issues of cross-cutting provincial importance as well. And I guess the final message is you're not confronting these issues alone. There are hundreds of people that have engaged in these webinar sessions and have put their hands up to identify that they're interested in taking a leadership position in proactively engaging in the policy debate that will really transform how clients receive care. So I just want to thank you for your participation today on behalf of myself and Janine, and I'm going to hand things over to Kathleen at the OCSA for final commentary.
Hi there, everybody. I just wanted to thank once again Dan and Janine for such a fantastic job of not only developing this content, but delivering it with such ease. It's incredibly valuable to you all, I'm sure. Please take the time to fill out your evaluation that will pop up as soon as you finish the webinar today. Your feedback is incredibly important to us. We want to make sure that we're providing webinars to you with theme and content that is important to you in your daily roles. You'll receive an email after this with all the links, the recordings, and again that evaluation piece as well. Please follow us over at LeaderShiftON on Twitter to get the most up-to-date project information, and our new website is leadershiftproject.ca. That's where you can also apply for our upcoming cohorts across Ontario for the LEADS 5-day learning series. That's an excellent opportunity, so come check that out. Lots of locations left in this fiscal year, and there will be more announced at the end of the summer. So finally, thank you so much for your time, and thank you for your interest in these webinars, and we will keep you up to date and apprised of any developments coming up in probably the fall for more in this series. So thanks so much and have a great afternoon, folks.